Okay, so thank you everyone again for joining. We're so glad to have you here today as we talk with Cesar and Joe about the BBB and health centers' strategies for sustainability and what we can do today to better understand our path forward amid all this uncertainty. So, again, this is an open forum. We want to hear from you, the questions you have, the things that are top of mind. So please drop any questions into the Q&A tool you can see on the bottom of your screen or the chat. And to start, please just drop, your name, where you're coming from, into the chat to introduce yourself. We'd love to hear who's here today so that we can better tailor the conversation. I'm going to pass it off to Cesar to do intros and kick off the conversation.
Thank you so much, Adrian. And yes, looking forward to having a robust discussion here and really want it to be an action-oriented discussion around not just level setting what is in this HR1, but what we can do about it. What are the practical things that we can do to ensure our own resilience against HR1 and what its implications are? Just as a brief intro, I'm Cesar Herrera, co-founder and CEO of Yuvo Health. What we do in a nutshell is support community health centers and only community health centers stay financially resilient and scale their mission through value-based care. But most importantly, I grew up as an FQHC patient myself. This is incredibly near and dear to my heart. A deeply personal mission for me to ensure that community health centers, wherever they are and whatever missions they have to serve their communities, stay viable in doing so. Super excited to have Joe Dunn from NACHC here joining this conversation as well. Joe, do you mind introducing yourself to the group?
Yeah, thanks so much, Cesar. My name is Joe Dunn, as you mentioned. I am the Chief Policy Officer at NAC. I've been with NAC for almost about 5 years. Before that, I was on Capitol Hill for about 11 in the House and the Senate, and really look forward to the conversation today and trying to answer any of the questions and think through kind of next steps around implementation and how health centers can be best positioned to, take care and mitigate any threats and look for the opportunities within this new landscape that we're going to be operating in.
Thank you, Joe. And again, we want this to be an active conversation. But first, it's probably important to just level set and get the lay of the land here. So, Joe, no better person than you right now to help our attendees really make sense of what exactly is in this big, beautiful bill and where does it stand now?
Yeah, so this is it's important to kind of start with that baseline and the One Big Beautiful Bill Act, which was the name of the actual bill as it was moving through the process, or as I've started to call it, OB3 or HR1, really is a pretty fundamental rewrite of some of the change or of the Medicaid program in a lot of ways. And so it's very important for health centers to be aware of the details and to kind of think this through and think about how it's going to impact you all. It was passed by very tight margins in the House and the Senate in the over the summer timeframe, and so it was signed into law by the president on July 4th. So you may have seen the signing ceremony, but if I were to distill it, there's a few core elements. One is around Medicaid community engagement or work requirements. That is a big part of the new changes within the Medicaid landscape. There's also new eligibility checks that are going to be required around the Medicaid expansion population. So doing those every 6 months, for example. There's other changes around immigrant health that want to be aware of, and then other things about state financing of how they're financing their Medicaid program. So things like provider taxes or state-directed payments that really are not necessarily as directly impactful to health centers outside of a couple states where there were some funding through these mechanisms that health centers got. But for the most part, just a way to think about it is that the states were using these mechanisms to fund their entire Medicaid program. And as you think of how that translates is if there's less dollars from the state that by leveraging federal dollars, then that could put more pressure on states. And so it's something to be very aware of. And, just to continue the need for advocacy around the importance of health center funding and the PPS rates, the value that health centers provide to the healthcare system in your community, in your state, and that connection with your state Medicaid agency. So that's kind of at a high level, some of the changes within the law. And one of the other things I guess I should mention also is there's a new $50 billion fund over a 5-year period for rural health transformation. And health centers are eligible for that. While there's been a lot of talk about rural hospitals, and obviously rural hospitals are an important part of the healthcare system in rural communities, rural health centers are just as important, if not more, when a hospital closes. And so
Hmm.
we want to really make sure that through that program, rural health centers are getting the funding that they need, along with other health centers in the states, because it's not just rural health centers that are actually named in the law. It's actually health centers and lookalikes across the board. And so that's just something to be aware of. About 50% or 50% of that funding goes to the states, the other 50% is at CMS. And while they're working out some details, we're already starting to do some outreach to CMS. And I know the primary care associations are doing that with their governors and their state Medicaid agencies to really make that case for funding within the law to go to health centers.
No, appreciate that, Joe. And it's great that you're pointing out that yes, there is a lot that can feel really dire and definitely detrimental to health centers if we don't do anything. There are also some opportunities that we can take advantage of that are written into this law. It's just a matter of how we can get through all of that and make sense of this really complicated law, really complex and convoluted HR one. Um, let's go into a little bit more practical details then too, because very few of the initiatives that are baked into this law are have immediate impact or immediate rollout. Can you give the group here a sense of what the expected timelines are for some of the rollouts of the various regs?
Yeah, and so it's important to also maybe put in a perspective a lot of the potential changes that were talked about early on. So, fundamental change of the federal share that goes to states, or harmonizing the expansion FMAP rate to the federal match of 90 cents on the dollar down to 50%, or somewhere in the middle. A lot of those things did not get included, right? But within the
Hmm.
provisions that did get included, they do have a rolling basis of, you know, coming out. And so we will start to see guidance from HHS on some of the changes, for example, around eligibility determinations starting this year. That rural fund that I mentioned, that will be a whole planning process where states will have to develop their plans, and then CMS will have to approve those plans by the end of this year, and then kind of have the funding available. But then some of the other things like Medicaid work requirements will go into effect a little bit later, and so it could be as early as the end of 2026. That's the original start date for the federal side. Now some states may go earlier than that if they have an 1115 waiver, and the law actually says you can start that earlier. And so some of those applications are already pending from or within CMS. But then there's also a 2-year potential delay that the HHS secretary can grant to states if they're acting in a good faith. And so that's just an example of, they may play out differently in one state versus another. And so really important to kind of stay on top of it, stay connected a lot through our webinars and our calls that we have, but then also connecting with your primary care association, your external partners like Yuvo and others who are going to be monitoring this. So those are a few different things. Some of the other changes that are a little further out are in 2028 and 2029, and that deals with cost sharing requirements for expansion individuals. We were able to make sure that health center services were excluded from that. So we were able to work on language to improve the build. So FQHC services are not going to be, subject to a cost sharing, but otherwise that's an example that would start in 2028, and then kind of has rolling out years. So there's some other provisions that go into effect in 2029. So kind of different time frame for different provisions within law.
Yeah, I think that's a really important tell here as it relates to some of these timelines going as far out as 2029. And in some conversations that I've been having with health center leaders, um, there are a few that are saying, well, maybe I don't have to do anything now. I'm going to take a wait and see mentality about this. Um, do you think that's detrimental at all? And if so, what are they risking if they wait too long to act or do something?
Yeah, and I'll just maybe say, and I should have said this at the outset, right? We were very disappointed. The fact that this law takes $1 trillion out of Medicaid is really concerning. And because of the 50% of their health center patients that are on Medicaid, 40% of the revenue, that is a concern. And so as we think of these changes, right, we are now going to operate in this new environment. And I think, you have to go in really with the eyes wide open of trying to, mitigate the impact as much as possible. So I would encourage people to start to think about this, to start to assess, okay, how many patients that you have at your health center are within maybe traditional Medicaid versus Medicaid expansion. What could you do to have that connection, that relationship through your primary care association or directly with your state Medicaid agency? Where do you have the connection with your members of Congress that, if we start to run into problems, how can you then go to them and ask for changes or, be aware of what's happening? So that education piece is really critical. And so I really appreciate your participation today on today's webinar. And then it's going to have to be iterative, right? Because these things are going to be changing as HHS releases guidance or CMS releases a rule. It's all going to be shaped, right? And so that's where I think having that mindset of being forward leaning, understanding that there will be changes, and then how can we really position health centers, in a way that we're a solution to some of these things, and not necessarily having the complete downside to this.
No, no, that's fair. No, appreciate that. Um, Now we're going to get into more tactically, what are the things that we can do? And Adrian just posted a poll out to this to the registrants here, just speaking as we think about it. It's like, how are you feeling about the OB3? And the results have come in, and it's all over the place.
Just,
And it's totally fair for us to probably feel a mixture of all of these feelings and trying to figure out how to make sense of it all, right? So that's really what we're going to have this discussion about is then, all right, tactically, what can we do? Where are those areas where it makes sense? And how do we lean into our partners and our stakeholders in order to enable it? Um, but before, should we go into this first question, Adrian, that's being posed?
Yes, so someone just posted a question. Thank you. There's been reportings that health centers are pausing providing gender-affirming care for trans and non-binary minors as well as adults. Does NAC or Yuvo Health have a position or stance on this?
yeah, so Cesar, I don't know if you want to answer or want me to go first.
You can start, and we certainly have a stance as well.
Yeah, so I there's certainly a lot of attention around this issue. You probably saw earlier this year there was a executive order around this issue. There's other attention in Congress, so multiple bills have been introduced around this topic. I would say, that we understand that healthcare is, at the local level, and health centers are going to make determinations based on their patient population. So, while we have talked about this issue in the past, including on one of our fast calls, I know earlier this year about the executive order. That's just something that we understand also that the care is going to be done. I do know that, like health centers. NAC wants to, ensure compliance with state and federal laws. And so this is an area that I think we're going to need to continue to watch and monitor to see how this may begin to change over time.
That's a great point, Joe. And just to speak to our position here on the Yuvo Health side, we are not a political organization. We don't dictate the set of services that are provided by any of our FQHC partners. But as a result of that, we deeply support and are very proud of how our FQHC partners have deployed the services to meet the needs of the communities that they serve. We have several FQHC partners that serve a predominantly LGBTQIA plus community, and will continue to support them in the work that they do, as we will with any FQHC, because we simply deeply care about their respective missions. So along those lines, let's talk now practically, right? What are the actions that community health centers can be doing right now to prioritize? And how I think of it is along multiple levels, right? Policy advocacy, what are things we can do from an operational standpoint? What we can do from a revenue diversification standpoint or a revenue preservation standpoint. And then also very deeply important is from a community health and health equity standpoint. Obviously, a lot of the things that we were talking about were upfront policy and advocacy. But Joe, anything more that you wanted to add there on what else we can do there on the advocacy front? And what is already, do we feel is fully defined or potentially subject to change prior to the rollout in 27?
Yeah, so I think one of the first things that all health centers could do is think through and look back at what you did during the Medicaid unwinding process, right? As part of the COVID pandemic, there was, the states received extra funding, and because of that, they were not able to redetermine eligibility, and so right that eventually stopped, and there was this massive redetermination process that all played out, right? We're all familiar with that. That is an example where we could think back to, okay, what happened in that scenario? And then, are there relationships that maybe you developed with the health plans that you could go back to, or you could, strengthen again and refresh to understand what it is, how this new environment, especially with the community engagement work requirements, that, you could lean back on that. Right? Are there other things that you could be doing? Other partnerships. Again, like I mentioned, the Medicaid agencies. There's going to be a significant number of new state administrative requirements that are going to be placed on them. So, is there a way that through those connections and communications, that health centers could be seen as a solution for the state Medicaid agency, and assist them in this process to build that goodwill, but also that opportunity maybe for future funding as well, right? And so those are some of the ideas that kind of immediately jump to mind. But then also looking at your own internal patient population, I think is going to be important to kind of scale what the impact could be for you, and having that connection also with your other community-based providers in your community, right? Are there other organizations that you may have similar patient population that may also be included? There was a number of SNAP changes, for example, in the law and other kind of social programs. So is there connections that you could be building right now that would pay off as these things start to play out? In terms of one of the things that maybe is not fully formed, but is beginning to take shape, is this rural health transformation program. So we do expect HHS will be releasing some guidance on how states need to be filling out their plans, and from there applying. And so, like I said, there's been some conversations that it seems like it's really only for rural health or rural hospitals. That's an example where I think we need to be forward looking. So NAC, in the last couple of weeks, we sent a letter from Dr. Ree to the CMS administrator, Dr. Oz, really outlining the importance of primary care within this fund, right? The value, the $1 spent to $13 of ROI spent within primary care, and all the data, all the research that backs up health centers being a solution to preventing and managing chronic disease, and how that's going to save Medicare and Medicaid funding over the long term, right? So this is an area where we think they want to go in the space of technology. Value-based care is one of the eligible entities or eligible uses within the program. So how maybe through technology, AI or something that may be out of reach for a health center right now, is this money going to be a catalyst for the adoption and higher productivity, higher patient and provider satisfaction? That's an area where we're really starting to think through and understand, the potential for change within this, but we're still waiting on some of the guidance and details from CMS.
So we do have a few questions that have come in. I'm going to start with Jesse, who dropped one into the chat. Do either of you feel that the best strategy is to work with our Department of Health slash state? And I would even expand that and ask if you could speak to, ways you think we can engage, health centers can engage with the state in general and what to expect from state responses.
Yeah, so I would say, certainly having that connection that with your primary care association is going to be important to have a kind of group response or group strategy as to what the dynamic is with your public health department or state Medicaid agency, because that's going to be so critical to present that unified message and strategy for those state agency officials.
And I can just speak to piggyback on that. The I never say that there's any one strategy that one should do over any others. I think there are always going to be a mixture of strategies that we should be thinking about to support this work because it is so varied and interdependent. But at the end of the day, um, the state is always going to be the one that will then dictate how Medicaid is provisioned within that particular state. They're the ones that are going to be setting the requirements for the health plans, and based on HR1, they're also the ones that could stand to be the most impacted from a funding standpoint associated with it. In our work in the markets that we're operating we have very meaningful relationships with both departments of health and state Medicaid agencies in both states, and actually working in tandem with them to help set the requirements for the health plans around how value-based care can actually be deployed for our FQHC partners. And we found them to be really open and engaging partners in this work. So I definitely encourage anyone to continue to leverage the state in that way.
Someone asked in the Q&A, we're hearing that community health centers are having trouble accessing their grants funding. How communicative has HRSA or other federal agencies been with keeping health centers up to date, and how can health centers stay up to date on that?
Yeah, so I saw that question. I would love to know. I know it said anonymous. I'd love to know more information because we have not heard that. Earlier in the year, there were some challenges that some health centers had around the funding freeze that was around our Policy and Issues Forum conference, and then that got resolved. And then there were some kind of other shorter delays that were addressed. I think the last HRSA BIPIC update, they did say that they've tried to push out all of the money to health centers. So if there's reports that there's difficulty accessing funds through BIPIC, I'd love to know about it and to try to track that down. So if you could reach out to me, and I'll put my contact information in the chat if you don't already have it. If it's other grants, I'd also love, outside of HRSA, I'd also love to know so we can try to scale what the potential issues. But I have not heard that, and I think HRSA certainly is trying to provide as much updates through those update calls that happen periodically, and we'll get as much as answers as we can, but would love to get more information on that.
Yep. We can share Joe's contact information and Cesar's after this, but to the person who asked this question, you can also just chat us three, the panelists, directly with more information if you'd like to do that in this call, and we can take a look. Next question. So this kind of has three prongs. I'm just going to read through all of them. Are health centers nationally seeing a drop in utilization or increase in no-show rates among patients who are foreign-born or undocumented immigrants? What can health center administrators and staff do to protect the confidentiality of those undocumented immigrants? And how are health centers approaching proactive messaging to those undocumented immigrants to curb the chilling effect of aggressive immigration enforcement?
This would be another one where it would be helpful to have some context. I have not heard of a drop in utilization or an increase in no-show rates among patients. The UDS data will be released, next week as part of National Health Center Week, I expect. And so, but that would be a look back at the previous year, right? That's not as in real time. And so, but I have not heard from anybody expressing that. I don't know if you all have heard that feedback from any of your, clients or.
We have not, and I think it's probably too soon to tell, but we hear fear, right? So I do not discount this person's sentiment because the language that's coming out of this administration is quite forceful around that requirement of every single patient that needs to come through the door. You have to document their immigration status in order to provide them care. Um, um, from what I know from our health center partners, they're not doing anything about that at this current state. And in many cases, they're doing lots of things to protect patients that are coming in and or potentially staff. So those there is it's incredibly important that many health centers really do lean into their mission and speak to their centers as a safe place for anyone to seek care regardless of their immigration status. So I hear you, whoever wrote this comment, that this is in direct odds with your mission.
Yeah,
But
and
it might be too soon to tell.
I'm just looking off. All of a sudden, the sky just opened up. It is absolutely pouring in Arlington, Virginia. So I was like, "Oh my gosh, we're gonna get washed away." Um, yeah, I definitely just echo, the concerns that we've heard. Without the or maybe the fear. Certainly we had a call around the PAROA, so that law, the 1996 welfare reform law that President Clinton signed, the reinterpretation of the guidance around that, and the connection of what is a federal public benefit. So that is something that we've had a couple of different calls on. And so there's materials where we've had attorneys through Feldman walk through what we know in that situation. I would stress that they've also suggested everybody take a breath, not to change policy right now, because what they're suggesting is that more information is needed to understand the environment. There is a comment period. NAC will be providing a comment, but also a template for health centers to, if you choose to, you can, express an opinion to the government around these changes through this template letter or a different letter if you want. But that is something that we definitely had a lot of interest in when we did this call around the new PAROA changes that could be on the horizon. Yeah, and just looking at the other questions. Oh, yeah,
Yeah, we Len has a question for
sure.
Cesar. Given the changes that the Triple B calls for in Medicaid, please give us your thoughts about health centers embracing value-based contracts for payment for service to Medicaid patients.
All right. Well, I'm trying not to be biased here, right? Given the work that we do is solely in value-based care, so I will say maybe the cohort of health centers that approach us kind of are right that might be a little bit skewed. But from what I hear from health centers and PCAs that are supporting their health center partners navigate here, what they've spoken to is that the triple B has really been a catalyst to force different ways of thinking and strategic initiatives around value-based care as a means to extract more value that they're creating in the system and bring it back to health centers, right? According to NAC data, I believe only 2 to 3% of the Medicaid premium is actually going to primary care costs that are served by FQHCs, um, and that is not truly representative of the value that health centers are creating in the system to keep patients healthy, keep them engaged in their care, and bring down total cost of care within Medicaid and Medicare. So value-based care becomes that really important catalyst to enable health centers to extract a larger percentage of that premium dollar, especially in light of potential cuts to Medicaid enrollment that'll be coming out of the OB3. So that's really what we're hearing is not necessarily. Almost sometimes I hear it as like this do or die moment for health centers to do something and get ahead of this, especially knowing that um, in a fee-for-service world with less Medicaid beneficiaries will come less revenue. So there is a need to preserve that revenue, increase that revenue, and diversify those revenue streams. I don't know if Joe, if there's anything like that NAC has a stance on as it relates to value-based care, given OB3.
Yeah, I would say, we understand that there's going to be a lot of attention around, value and demonstrating and being reimbursed around value. So I think within the value-based care space in general, we need to be having measures that reward primary care, the measures that reward health centers to, we often will think back to, the fact that only 5% of federal healthcare spending goes towards primary care. In other countries, it's like triple that. And so, we need more money into primary care. And if you were to really focus on the value that health centers can provide, we would be getting a lot more of that. So it's something I think we're going to digest around these changes with the new law, but certainly want to work with partners like you all and the health centers to really guide that discussion and the conversation.
Yeah, appreciate that.
Okay, so Jesse had asked in the chat, can we please talk about the details of the BBB, for example, grandfathering of the DPP and the gradual reductions? I know we did provide an overview at the beginning of this call, and we will share the recording after this, but maybe we could talk about that example for a few minutes and weigh in there.
So I'm just looking, where was that question? I just want to make sure I understand.
Yeah,
Oh, it's
Jesse
in the
dropped
bottom
it
of
in
the
the
chat.
chat.
Grandfathering of the DPP. I'm not quite sure.
Diabetes prevention program.
Oh, okay. That was not an area that we focused in on as much. So Cesar, I don't know if you have an opinion. I would probably have to get back to you, Jesse, about that. But that's not something that, we were really focused around Medicaid as a whole and some of the changes like around the cost sharing that I mentioned, and the rural fund. But
Yep. Thank you. So I'm going to answer a question from Danielle, and then if people have questions specifically around, or especially around actions that health centers can take and what they can be doing, today, tomorrow, in the near future, please continue to drop them into the chat or the Q&A. We're really appreciating your questions here. So Danielle had asked, how do we reconcile the executive order not to use federal dollars for undocumented immigrants, excuse me, versus the prior law that mandated that we cannot ask for proof of immigration status?
Yeah, so this is one where I know our attorneys have talked about, and so would definitely encourage you through our Docebo platform. And if you need the link, just shoot me an email, and then we can make sure that you have the information. But you're exactly right. There is a previous federal law. I think it was not from the original '96 law, but it was added later on. I think in 1998 that says that nonprofit charitable organizations do not have to verify status, right? And so that is an important, kind of backstop to think about and understand, okay, how are we doing this? And one of the things our attorneys have highlighted is, if there's knowledge that an individual is here as a patient and undocumented, that is something that may be different. But the real crux of it is we have to understand what HRSA is going to do moving forward after they were to operationalize these changes or suggest that after the 30-day comment period. And so this is an example of, it's a little bit unclear. Another part of it that is another dimension specifically for health centers is Section 330 right now says that you're required to provide care for all residents within your service area, right? And so how does that underlying federal law, this other federal law around verification of status for nonprofits and the special rules there, and then this new interpretation, how do all those things intersect is, things that we need to have more information on and an understanding from HRSA. I would just say this is an example where it would be good to highlight that. And I know that that's going to be part of our conversation with our comment letter. And so you can look to that when we send it out, or as NACHC sends out our comment letter that we plan to, talk through. So appreciate the point. It is confusing because of all these different things in this intersection and, the potential conflict within these previous federal laws and the interpretation.
Thank you. So while we wait for more questions, Cesar, I don't know if you want to return to the
Yeah.
conversation that you two have been having about the actions that health centers can be prioritizing.
Yeah, no, definitely. So we've talked a lot in regards to the different policy and advocacy initiatives that we can take on as it relates to supporting NAC in your comment letter, as it relates to us pushing within the states. But then let's talk about internal operations. Let's talk about things that we can do to see how we can withstand potential cuts in Medicaid enrollment, for instance, or what we can do to diversify our revenue streams. What do you think are some strategies or actions, Joe, on the revenue diversification or revenue preservation front that that you all are NAC are thinking about and pushing to your constituents? I certainly have thoughts there too.
Yeah, would love to hear your thoughts as well. So one of the things that we have kind of been pushing for some time, right, is ensuring that health centers get paid at an appropriate level and for the appropriate number of services, right? So thinking about who is a billable provider, what is an update within the PPS system, or are there other things, especially within Medicare? For example, Medicare PPS hasn't been updated since the very beginning when it was started about 15 years ago. So that these are areas where we're really trying to always think about, okay, how can we help with sustainability at the health center to ensure that you have the individuals, right, the workforce that's going to be there to take care of patients, and that workforce is compensated in a way that is sustainable moving forward. And so we think of it that there's definitely actions at the state level, and so trying to help primary care associations, and some of them have had significant wins recently. And so I used to work in the Connecticut delegation and would hear a lot from the Connecticut health centers that I, cherish those friendships. But they would often say, look, we don't get paid enough by the state, and our costs have not been reflected, or the costs haven't been reflective of the payment. that we get. So they just recently were able to get an increase, right? So that's an area where
Hmm.
that was for the Primary Care Association, but we were very kind of involved in helping them think through certain aspects of it, or as a resource to think that through. That's an example of what NAC does a lot with primary care associations. Other things on the federal level, like I mentioned, Medicare PPS, that's something where we're trying to push forward. There's other things. The PACE program is one that we think has a lot of potential for health centers moving forward. There's only about 2 dozen health centers that have sponsored PACE programs. That's an area we'd love to have that continue to expand and move out to others, knowing that the Medicare population is our fastest growing patient population for across the patients of health centers. So different areas where we want to think about diversification. 340B is another one where we're constantly trying to think through solutions to get that to be more sustainable. There was a new announcement today that I was digesting earlier this call about a rebate model, and that is late breaking news, but it is limited. It's only a pilot program right now, but that's something that 340B is another one. We need to turn on the spigot again for health centers so they can reinvest those savings back into patient care moving forward.
Yeah, no, those are really great opportunities that I think are incredibly important for FQHCs to really think about how we can be creative in different and identify those different opportunities that we can lean into our strengths. How I've been thinking about it a lot too is as we think about it, knowing that there are so many important interrelated and interdependent stakeholders that are going to be deeply affected. Is how do we lean into more partnerships? How do we lean into probably more creative and innovative partnerships that health centers might not have thought about before. Um, Obviously, we already talked about the states. There are also meaningful partnerships that you can have with the health plans who are also set to be really deeply detrimentally impacted by the OB3 and hold the purse strings for many of the initiatives that would otherwise be reimbursed under Medicaid. How can you lean into that so that they can support you in your mission? There's a lot of really interesting ways in which they can do that. Others is in the realm of technology partners. There are a lot of really important, interesting point solutions on the technology side, many of which are paid through Medicaid plans, not directly by the health center, that can really support the work that we're doing. Particularly, if we think about many of the regs that are coming out of OB3 are really relying on um, administrative barriers creating the cuts in Medicaid enrollment? And what are things and technology partners that you could work with in order to support you to ease in that process and to um, keep your patients enrolled in Medicaid? There are two in particular that we continue to have conversations with. One is Fortuna Health that has this really seamless consumer-based application for Medicaid enrollment and re-enrollment, and are already really diving in to prepare for work requirements in the various states. And there's another organization called Mindset that is doing a lot of really great work to support Medicaid beneficiaries and not qualify for SSI and SSDI benefits. And there's a lot of different things that I feel that health centers can do to strengthen and build up new partnerships to support in this unified mission that we all have.
Those are great points. I know we've had some conversations with some of those tech companies, and I think there's potential to smooth out some of these enrollment issues.
Yeah, and I would say too, not just to plug NAC a lot and the PCAs, is I know that NAC is doing a lot of really great work to to um, open up the idea of within the tech community to partner with health centers and realize that health centers are a viable partner in that realm. And you're doing a lot of really great work to vet these partners to make sure that they are of like-minded mission. Because the last thing that we want as well is for health centers to be exploited by tech.
For sure.
Any other things that you think of as just other considerations that the health centers could be taking now to get ahead of all these changes that are happening for 2027?
Um, again, I think at first step, understanding what is out there, what is the landscape going to look like, what are the different rules? And so we've tried to provide, a good summary of that and, here, but then also in other calls and materials. Um, that next step of, okay, assessing what your patient population, what your community health center could be facing, I think is, a natural part. And then really taking that next step of forming those partnerships, like you mentioned, with tech companies, or like I said earlier, the state or through the primary care association with the state. That's kind of how I would kind of see the order of operations and just really tending the garden on this, right? Not kind of putting it aside and thinking, okay, well, I'll deal with that in 2027, but constantly trying to rethink, okay, what are we doing? How can I look at this? How can I prepare? And maybe it is through a tech platform or it's, by staying engaged and knowing it, being involved. So, we have these monthly calls, we call them policy pulse calls, where it's myself and the rest of our team. It's the second Wednesday of the month at 3 o'clock Eastern, where we go through soup to nuts. But that's only one call that we talk about policy, right? There's other things that we can be doing that, one of the things that's top of mind for us right now as we get into the, National Health Center Week next week, and then a couple months is our health center funding, right? That's going to be a really important part where all of our health center funding expires at the end of September. And so maintaining that connection to your member of Congress, right? It's going to pay dividends. I always, I was a congressional staffer, like I said, for 11 years. I became friends because I was within the Connecticut delegation for 8 years. It was a little unusual that I stayed for so long, but it was great because I could call up a health center CEO and say, what's going on? What's happening? Or they would
Mm.
call me up and say, hey, Joe, you got to get Senator Murphy to do X, Y, or Z. And I would immediately know that that's a priority. And so those are some of the things, like on a very practical level, be involved, assess what's happening at your health center, what could happen, and then build those relationships. So kind of three-step process that I would suggest as we think about the next, 6 months, 3 to 6 months to beyond.
That's really great to say. You actually got ahead of it because the question I was going to ask is what are the things that the health centers can do to stay engaged and keep up to speed on these regs? And it's great to see that NAC has a ton of resources available to keep its constituents up to speed. And any other things that you think that they could be doing, or other trusted resources that you would recommend?
Uh, So I guess, beyond NAC, certainly through partners like you all,
Mm.
maintaining that perspective, coming to events, either the PCA conference or the NAC conference, to make those connections that maybe you don't have the partnership, but through, an event like that where you can, start to build it and seek out connections, I think would be other things that I would recommend.
That's great, Joe.
Does anyone have any last questions for Cesar and Joe? We're entering into our final few minutes in the time that we have together. So if you have any questions or if you just want to weigh in on maybe some of the actions that you have been taking, whether they're things that Cesar or Joe mentioned or not, we'd love to hear that. Um, okay, it looks like Ludi has a question here.
Yeah, I really appreciate that, Ludi, and would love to connect with you. One of the things that we think is so important is this longer term funding and increased funding, right?
Wait, you
So,
know what, Joe?
Oh,
Sorry, I don't want to
yeah.
interrupt you. They only sent the question to us, so I'm just going to read it real quick so everyone
Oh,
can
okay.
hear the
Sorry.
question. All
Sorry.
good. Sorry to interrupt you. So, Joe, based on your role at NAC and your deep work on policy and research, you've emphasized the urgency of longer-term funding for health centers. With funding set to expire on September 30th, 2025, what concrete advocacy steps should health centers be prioritizing now to ensure sustainability beyond that point? Okay,
Yeah, so
thanks.
again, a great question of this, because we really do believe increased funding is important along with that longer term time frame so you can plan, so you have an understanding. We've operated, you may know this, but health centers have operated under six continuing resolutions. So in the
Hmm.
normal everyday speak is just moving the date in the legislation and saying, okay, well, instead of the funding running out on September 30th, now it stops on December 1st. Now it stops at March 10th. And all of these things really, one, a signal to the health centers and your staff, right? And it makes it more challenging, right? What is going to happen, right? Thankfully, we've always gotten extensions, but we want a longer term or longer time horizon so you are able to plan and make investments and understand that you're going to be taken care of, right? That increase is also important because we know we haven't had a base grant adjustment since 2015. Right? You are experiencing financial challenges, and those challenges are leading to some health centers reduce staff, close sites, other things like that. What we saw earlier this year with the federal funding freezes, some people were having to make really tough choices because they couldn't have funding and the payroll was going to run out, soon. So that's an example of we need longer term certainty and we need an increase because that foundation needs to be supported of the health center, right? And so we have been pushing for this increased funding, longer term funding. Congress has not cooperated thus far, but we're going to keep at it because that's what we're going to do. Health centers are top of mind. So what I would suggest in terms of concrete steps is make sure that you're signed up as an advocate through our Washington update so you know what's happening and you can take action, right? Through that system, if we send an action alert, you can go online and say, all right, I live in zip code 22213. Here's my representative. Here are my two senators. I'm sending them an email right now. Maintain that, right? We have two fly-ins scheduled, right? So that's where you can come into DC and you can push your message on the Hill directly. So we got that from September 16th and 17th and another one in December 9th and 10th, because I figure just knowing Congress, they're going to push it probably from the end of September to some point in December. And I want to have it already scheduled so people can come and it's planned out, right? If you can't make it because of finances, that also works. We want you to host a member of Congress, bring them in,
Mm.
invite them into your health center and say, look, seeing is believing. Let me sit down with you, tell you about our patients, have you meet with the individuals on our staff, meet the providers, right? So have that connection with those members of Congress and their staff to really emphasize this is critical. This is mission critical stuff. If we want to reduce chronic disease in America, there's no better way to do it than investing in health centers, right? So those are some examples along with the calls that I mentioned, making sure that you're looped in with those that are going to be really important as we move forward.
Thank you. Any other final questions? And while people maybe enter one last question, if anything pops up, Joe, do you want to share the work that you all are doing at NAC next week for National Health Center Week?
Yeah, so thank you so much. We are so excited about this. National Health Center Week is just such a great time of year. It's one of my favorite weeks and appreciate Yuvo Health's sponsorship of it. It's incredible to work with you all on this. It is also the 60th anniversary of health centers, right? So we believe that this is just such a critical time to obviously look back at all the history and then think about what is going to happen in the next 60 years as we, want to chart the future. So I know I'm going to be traveling. A number of our staff are going to be out there. We want to see any events that you're doing. So post them on social media, tag your member of Congress, tag us, make sure that you, really celebrate it for your patients, for your staff. I know I'm going to Louisiana and Arkansas. I'm looking forward to connecting with health centers that I haven't been. I haven't visited them in person to learn about what's going on in their communities and what they need. And so, that's an example of what we're trying to do. And again, through sponsorships like with Yuvo Health, we're able to help, the health centers in a lot of ways defray some of the costs of any events and things like that. And that's so critical because we know how challenging the environment is right now.
We're really excited to celebrate health centers and all the work they do next week. It's an important thing to pause and step back and look at.
Yep.
Agreed.
Yep.
Agreed.
Um, we will also be at NACHC in August. We're really excited to attend. So Joe, hopefully we see you there. And anyone who's attending this call today, if you're also going to be at that conference, we would love to see you. So please come over and say hello.
Yeah, definitely look
Yeah.
to seeing you all in person and meeting health centers. But yeah,
Yep.
sorry.
Oh, I was just gonna say, this last 50 minutes has really flown by, and this is a really complex conversation. It's very multifaceted. We're only just introducing this topic and just barely scratching the surface on what its implications are and what we can do about it. So I encourage us all to continue the conversation, continue talking to each other, and know that there are resources and partners available to support you as you think through strategies to get ahead of, to protect yourself, to stay resilient in light of the OBBB. Um, and and as we say as well on the UVO side, is we will always be a resource regardless. So like Adrian will be sharing our information to everyone here, both mine and Joe's. So don't be shy. Please feel free to reach out to any of us either via email or if you will be attending NACHC CHI conference in August later in Chicago, please do reach out. Love to meet you there and continue the conversation at that time too.
Yep. So keep an eye out for recording a summary and contact information so that you have the available resources you need to see what we talked about today and continue the conversation. Thank you, everyone, for joining.
Thank you.
Thank you, everyone.
Bye.
Here.